Welcome to the conference session titled Living with PNH. Thank you for joining us. My name is Derek Admana, the marketing coordinator, and I will be moderating the presentation today. As we get started, we recognize the generosity of the corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon in the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get all questions. When asking questions, I respectfully ask you to do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speakers cannot answer any specific questions related to your healthcare. Today's specialist is Bhumika Patel. Dr. Patel attended medical school at St. Matthew's University School of Medicine, completed a residency at Greenville Health System, and 2 fellowships at the Cleveland Clinic in Ohio. Dr. Patel is a member of the transplant and malignant hematology department at Prisma Health in Greenville, South Carolina. She specializes in caring for patients with bone marrow dysfunctions, including aplastic anemia, MDS, and PNH. With all that said, welcome, Dr. Patel.
So today we'll be talking about living with PNH. We'll talk about a review of diagnosis, complications, and treatments. PNH is a hemolytic anemia that arises from a somatic mutation in the PNH gene, which occurs in the stem cells. It causes defective synthesis of the GPI-anchored proteins, specifically CD55 and 59, leading to the development of PNH and its clinical manifestations. Note, PNH can be classified de novo or arise from aplastic anemia. It's characterized by chronic intravascular hemolysis due to the action of the uncontrolled complement system on the abnormal red blood cells, lacking the CD55 and 59, which regulate our complement system. And PNH RBC slice more readily in the presence of the activated complement system. But not only that, we know that the PNH platelets and granulocytes are sensitive to the complement system also. Here's just a simple illustration of how the PNH mutation is acquired. It's an acquired somatic mutation in the stem cells, and how that PNH clone can expand over time and grow. And so you can have 3 different types of PNH. You can have classical PNH, which is de novo. You can have PNH arising from aplastic anemia, which stresses the importance of watching the PNH clone. And you can have a subclinical small PNH clone, which does not expand at all. The basis of it's really important to understand the complement system because it is the pivotal part of the pathogenesis and the physiology of PNH. The complement system is an intricate pathway, basically integration of the classical lectin in the alternative pathway. It's composed of proteins that regulate our immune system. It circulates normally in inactive form, and many different events can activate the complement system, such as trauma, stress, and in PNH specifically, the lack of CD55 and 59 activates the complement system. Here's an important illustration of the complement system by Dr. Gerber and colleagues, where it highlights the important components of it in PNH. So the classical lectin and alternative pathway all converge on C3, leading to C5 and the membrane attack complex. In PNH, we can separate the complement system into proximal and terminal. The lack of CD55 and 59 activates this complement pathway. Specifically, CD55 regulates the proximal, and 59 regulates the assembly of the membrane attack complex. Because of the lack of these proteins, we have chronic intravascular hemolysis, which is the hallmark of PNH. Currently, we have 3 FDA-approved therapies for PNH. 2 terminal complement blockades of C5, eculizumab and ravulizumab, and most recently approved pegcetacoplan. Note, extravascular hemolysis is noted in about a third of patients with PNH, which we'll get into details as we get further into the discussion. Clinical presentation of PNH. So many patients, there's a delay to diagnosis, and that is the most important thing that we need to bring more awareness to PNH. Even though it's a rare disease, it's not rare. And I think it's important to keep on your clinical radar when you think about differential diagnosis from the practitioner side and from the presentation of different patients that you may come across in clinic. So patients present with hemolytic anemia. So these patients may present with fatigue, back and abdominal pain, headaches, esophageal spasms, renal insufficiency, thrombosis, and dyspnea. Thrombotic complications is one of the hallmarks of PNH untreated, where patients may show up with a blood clot in an abnormal location, such as Budd-Chiari syndrome, which is the thrombosis of the hepatic vein, intra-abdominal, cerebral, or venous sinus thrombosis. Thrombotic tendencies are enhanced in pregnancy in patients with PNH. Exacerbation of hemolysis also occurs in patients with PNH in the setting of infection, surgery, or transfusions. Note, aplastic anemia can be diagnosed before or after the identification of the PNH clone. And PNH clones are present in about 30 to 40% of aplastic anemia patients and in about 20% of MDS, but usually those clones are small. There is an increased incidence of clonal evolution in patients with PNH, so that's something important to monitor for in patients when you're treating them for bone marrow failure syndromes, especially acquired aplastic anemia and PNH. Most workups entail, so when patients are being evaluated by a clinician, you may notice on your labs, you may note elevated LDH, which is a marker of the red blood cells being hemolyzed in our blood. D-dimer elevations, low haptoglobulin, increased bilirubin may be noted on your comprehensive metabolic panels and Coombs test, and either elevated or decreased reticulocyte count. It's important in de novo PNH will note a more elevated reticulocyte count, but in patients where there's a component of bone marrow failure with aplastic anemia, the reticulocyte count may be on the lower side. There's no specific morphology of the red blood cells in PNH on a smear, but the bone marrow biopsies in these patients may note erythroid hyperplasia, or you may have a hypocellular marrow. It's not necessary that you need to do a bone marrow biopsy on all patients with PNH, but if there's concerns of a component of like pancytopenia, you want to get one just to assess the cellularity of the bone marrow, because there may be aplastic anemia along with PNH. Some of the late occurring, in patients with PNH, there could be late occurring iron deficiency anemia because of the chronic hemolysis, and also because of chronic urinary loss from the intravascular hemolysis. It is normal to see some degree of leukopenia and thrombocytopenia in patients with PNH. How we diagnose PNH. So bone marrow biopsies help us assess what disease are we dealing with? Are we dealing with aplastic anemia in PNH? Are we dealing with a small PNH clone in the context of hypocellular MDS? But usually with classical PNH, which is de novo PNH, you could diagnose these patients by flow cytometry due to the increased sensitivity of detecting small abnormal population cells. Because monocytes and granulocytes have shorter half-lives, and the numbers are not affected by transfusions. Analysis of the GPI anchored proteins on neutrophils and monocytes are preferred when you're running diagnostic testing to evaluate patients for PNH. The Flair assays selectively bind to high affinity to GPI anchored proteins of most cell lines, and most useful to assays the GPI anchor on granulocytes. What's important in the diagnosis, the diagnosis of PNH with flow cytometry is critical and where it's run, knowing where your labs are being done and keeping that consistent. So that way you can monitor your clone size for a clinician from a clinical perspective, and if there's any other concerns about the clone size as you're on treatment. When we talk about PNH, there's three different types of, when you look at your flow cytometry, there's three types of PNH clones. Type 1, where there's no deficiency in CD55 and 59. There's type 2, where there's partial deficiency in CD55 and 59 markers. And it's type 3, where there's a complete deficiency of CD55 and 59. What's important in this is knowing you can have a type 2 clone, which is not showing frank hemolysis, and in a smaller type 3 clone, but this is where it's important to discuss the type of clone you have with your physician, so you understand the biology of why you may be having overt hemolysis compared to more subclinical hemolysis. When we think about PNH therapeutics, we're thinking about it from many different angles. We're thinking about how can we support these patients, how can we help with increased red blood cell production, and we're thinking about the hemolysis itself. So most of our patients with supportive care, we support them with transfusions for the anemia. We can treat them for iron overload if that's progressive. and anticoagulation if there is a thrombotic event in these patients prior to their diagnosis. But we know with the complement inhibition therapy, the risk of thrombosis is decreased. In certain patients, you may want to check a EPO level because if their reticulocyte count is low, they can benefit from erythropoietin stimulating agents to help with that red blood cell production. You want to evaluate for nutritional deficiency, and if there is a component of bone marrow failure along with the PNH, patients may benefit from immunosuppression therapy, and that could be with anything that's cyclosporine and tacrolimus, or you could give these patients can benefit from ATG if there's the aplastic anemia, the disease is dominating in the context of the PNH. Anabolic steroids can also help with red blood cell production. So currently, there's three therapies approved for PNH that help with decreasing hemolysis and controlling that, and it improves quality of life, decreases transfusions, and also we know it decreases the risk of morbidity and mortality that's associated without complement inhibition therapy. So current therapies for PNH that are FDA approved, we have eculizumab and ravulizumab, which are humanized monoclonal antibodies. Both of these bind to C5, inhibiting the terminal complement activation, and decrease hemolysis of red blood cells, the risk of thrombosis, but does not fix the innate defect in the hematopoiesis. It reduces intravascular hemolysis, but not extravascular hemolysis. That's really critical because we know there's patients who can be on optimal C5 therapy, but still have ongoing hemolysis and extravascular hemolysis. And so they may still having symptomatic anemia and evidence of hemolysis, in which we'll talk about and targeting that. It's important to keep up with your vaccination history because if you're vaccinated prior to initiation of therapy, but maintaining vaccinations every 3 to 5 years is critical because there is a risk for complement inhibition therapies of having meningococcal infections. That risk is very low. The most recent therapy that's approved is pegcetacoplan, which is a pegylated penta-kappa peptide. It binds to the complement at C3, so it's an inhibition that's more proximal in the complement system. It is inhibiting proximal complement activation by decreasing hemolysis of red blood cells and thrombosis. And once again, it does not fix the stem cell defect of having the PNH bone. What's the difference between the C3 and the C5 inhibition is in the C3 with pegcetacoplan, you're getting intravascular and extravascular hemolysis blockade. You're getting improvement on both ends. And it's important in these patients too, you're getting vaccinated 2 weeks prior to initiation of therapy for encapsulated organisms, and keeping up with your vaccinations is critical. So what's interesting is that we have 3 approved therapies, and making use like what do we make of it, right? How do we use these therapies? To date, we have the most long-term data with C5 therapies. So and that's very important to keep in mind. And we're awaiting the results of the PRINCE trial to see where pegcetacoplan will fit into line. But there are patients that are being initiated on therapy with pegcetacoplan too as first-line therapy because of this FDA-approved indication. And beyond that, we know that there's 3 FDA-approved therapies, but there's ways we can improve therapies for patients with PNH, and there's new therapies in pipeline for these patients. So when we go back to the complement system, once again, it's important to know that where are these agents being targeted. And we briefly touched upon the 3 FDA-approved therapies, but there's so many new different drugs in the pipeline that are going to be very critical for us to at least touch upon, but also for patients to keep in mind, because there may be ways to improve their therapies and their outcomes with patients with PNH. So as we look on the slide, on the alternative pathway, currently there's several drugs that are in clinical investigation. There's factor D inhibitors, which is BCX9930, but BioCryst. We have factor D inhibitor by Achillion and Alexion, Danicopan and Alexion 2050. And what we expect is it's blocking proximally and it's going to help control extravascular and intravascular hemolysis. And the data is still, all of this is still in clinical trial, but data has been the preliminary data has been quite exciting. We also have factor B inhibitor, which is by Novartis LMP023, which is in clinical trial with a Find Point trial. And we have other C5 inhibitors, such as crovolumab and pozolimab, that are also being investigated as optimizing therapy instead of IV infusions, having self-injectables for these patients, just like similarly to pegcetacoplan, just a different target. So when we talk about C5 inhibitors specifically, currently we have eculizumab and ravulizumab. They have improved patient lives, they've helped with improving anemia and thrombosis, the risk of thrombosis. The downside is it is a lifelong treatment. There is a segment of, there's a minority of patients that don't have a full response, and some patients remain refractory despite optimal therapy. And so there could be major inconveniences, which I think with the approval of ravulizumab has made that inconvenience improve for patients. And there's a risk of meningitis. I think when initiating therapies for patients with PNH, you need to have an important risk versus benefit discussion with your patients and actually initiate therapy when clinically relevant hemolytic anemia is actually occurring in these patients, but monitoring these patients very closely. Discussing personal goals and peers is also crucial. As a patient, when diagnosed with such a rare condition, you want to make sure your care is in good hands, and you want to make sure you're getting the best treatment out there and making sure there's good data, safety data, because you will be on therapy lifelong. Some of the new other therapies that are coming down the pipeline, they're still under investigation of crofelemer and zolbetuximab, and these are self-injectables. And right now, we're awaiting data for the Camador trial and Access trial to see where they will fall in the pipelines in the armamentarium of treating patients with PNH. We're suspecting that the safety considerations will be similar for the C5 inhibition with the complement system with infection rates, and similar, it may be similar and efficacious, but to the C5 inhibitors that are already approved. But we're worried that the patients that are non-responders to eculizumab, they may not respond to these therapies. But that in only data, once we have mature data, we'll be able to tell further. C3 inhibitor that's currently approved is pegcetacoplan, that is a self-injectable. And in the clinical trial, the Pegasus trial, it appears to be superior to non-responders with eculizumab and can replace infusions of anti-C5 therapy as an initial therapy. It makes patients independent of infusion and because of self-injections. And it is because of its mechanism of action, it improves extravascular hemolysis and intravascular hemolysis, and it's a twice weekly subcutaneous injection. The main concern here is we're waiting for data to come out from the Prince trial to look at the long-term safety data compared to C5 in managing these patients in the long run. And there's other therapies for C3 therapies also in development. Other therapies that are also being investigated further are the factor D inhibitors of BCX9930, danicopan, and Lencia 2050. These are oral therapies, which actually makes is very critical and very important because we've been used to doing IV infusions and most recently subcutaneous injections. These oral drugs are either twice a day or 3 times a day, and so far have shown to be effective in combination with C5 inhibitors and as monotherapy, which is quite exciting for patients who've been used to these IV infusions. And if somebody has to take a pill, they may make their lives more convenient. Danicopan is being investigated as an add-on therapy to C5 inhibition, and so far responses have been very impressive. And BCX9930 is under investigation, will likely be developed as a single agent based on the clinical trials. Both of these therapies currently, based upon the data we have, are probably can be used as rescue therapies in patients that are refractory to C5 inhibition. It improves extravascular hemolysis because of its mechanism of action in the proximal complement system. However, once again, we have limited long-term safety data compared to C5 inhibition. So it's important as this data is maturing, we'll need to know how is this going to fall in line with our treatment paradigm for PNH as more data comes out. From factor D, we go to factor B. So a little bit downstream in the proximal system, we're once again, factor B is also an oral inhibitor that's being LNP023. It's an oral drug that's twice a day. So far, data has shown it's been very effective in combination with C5 and as well as monotherapy. Appears so effective that the aim of the trial is that they have a complete remission rate and will likely be developed as a single agent or as a rescue in non-responders to other therapies. It also improves extravascular hemolysis along with the intravascular hemolysis. However, there is limited safety data compared to C5 inhibition. And so what I would say for now is let's watch and wait and see how the data matures. That we are definitely going to be seeing an expansion in different therapies and figure out which patients need which therapy is going to be crucial for the discussing with your physician, because I think it's going to be first and foremost, we will have to know which therapies to use in the refractory patients and which patients we use C5 inhibitions, C3 in these monotherapies as they're FDA approved. In conclusion, PNH is an acquired fungal disorder characterized by deficiency in the GPI anchored proteins, CD55 and 59. It's diagnosed by flow cytometry, characterized by chronic intravascular hemolysis due to uncontrolled activation of the complement system and associated clinical complications such as thrombosis and end organ damage. Currently, there's 3 FDA-approved therapies, eculizumab, ravulizumab, and pegcetacoplan, for more choices for therapy to come. So how can you make a difference? And your physicians are going to be your biggest advocates in making sure you get the right therapies and are up to date on the therapies that are coming down the pipeline. But how can, as a patient, can you make a difference? So there is a global PNH registry, patient registry. And basically this global patient registry is basically helping us, further research in rare diseases, and your data can be used to developing other therapies. The purpose is data collection on patients around the world to share this information about PNH that will fill current and future gaps in research. Goals are to empower and unite the PNH community through shared knowledge, collect data on demographics and quality of life, treatment, diagnosis, and PNH symptoms. Increasing PNH knowledge and understanding the progression of the disease is also critical because we know there's evidence of clonal evolution. But this increase in knowledge will help us develop better therapies for these patients, as we've already discussed briefly, that are under current investigation. And so I think this is a great way how you can help your physician scientists improve research for PNH. Some of the key features of the global PNH patient registry is it's a natural history study that consists of electronic surveys to collect information about the patient experience and disease progression. Patients and their caregivers or guardians can enter this information from anywhere in the world, making it easy to contribute. The data is made anonymous and stored securely in a registry, and patients will have access to all their collected data. Patient participation will be ongoing with periodic updates and surveys will add in. AAMDS may share the de-identified data with individuals or institutions conducting research and clinical trials, as approved by the registry's medical advisory committee and patient steering committee. Thank you. I'll take questions, and I would like to thank AAMDS and all the patients and all the physicians that are out there treating bone marrow failure conditions and helping us push the bar to the next level.
Great, thank you. So as we're waiting for any questions online, does anybody here have any questions?
I have a question. So it's a biased question coming from the industry side of things. But when you're in the clinic, you did such a great job talking about the potential future options down the pipeline. So when you're in clinic and educating patients about some of these options, are there common questions or points of confusion as you talk about, especially like looking, proximal versus the terminal side of things, and just questions that we can try to, understand to help patients?
Right now, I think there's an important, I think all the PNH experts are figuring out how are we going to incorporate this into the standard available therapies, right? I think the longest term data we have is with eculizumab, right? And there's mature data, there's registries for that. We know how these patients are doing in the long run, and ravulizumab too now. I think the data is, we have more strong data for the C5 inhibition upfront. And I think with pegcetacoplan added to the, we're figuring out how are we going to sequence these therapies. And I think sequencing of these therapies is going to be very crucial. And I think that's where guidelines are going to be imperative to guide patients, especially like guide patients, not only that because they're hearing all about all these new agents, but physicians especially, because most PNH patients, they are seen that they're treated in the community. And they, we need to empower our physicians in the community and at academic centers. And how are we going to guide all the physicians to educate our patients? So I would say currently the most data, long-term data for safety and efficacy of the C5 inhibition. And I think with more data from pegcetacoplan, I think that's going to be incorporated also. But I think, now with insurance companies, pegcetacoplan is being used up front for patients with PNH. And I think we're awaiting the results from the PRINCE trial for mature data from their long-term data. But where the oral therapies come in, I think these oral therapies have been, at least from my clinical experience, these oral therapies have helped those refractory patients who are not getting optimal benefit from C5 therapies. And I think that's where we're going to get to be able to treat a minority of these patients that are refractory, a third of them, that are not getting optimal benefit, I think that's where factor B and D inhibitors are going to be really imperative. But the fact that they're efficacious as a monotherapy, of course, there's some like, you're waiting for that mature data because we want that data so we keep our patients safe and improve their care.
So we didn't get any questions online. So that concludes our session. So thank you, Dr. Patel, for sharing your time with us and expertise. If you would like to watch the session at a later time, it will be available on the conference platform in the next hour by accessing the session and clicking on replay, or by navigating the on-demand tab in the platform. If we were not able to answer your question today, you can send it to us at any time in 3 ways. First, send an email to help@amds.org. Second, call the AMDSIF helpline at 800-747-2820, extension 2. Third, submit a question on our Facebook page. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan future education programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. The next educational sessions will start in approximately half an hour. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 39 years. This concludes our session.